Okay, guys, so I'm going to do a quick case study wrap up for everything from Module 5 and 6. If you are feeling uncomfortable with the cancer subject, I know a few people had expressed that. I did do a short, I think it was 18-minute long video on cancer. I will do a little bit of it in this one, but definitely pay attention to that one for more review on cancer. Okay. So starting out with hypersensitivity, I didn't do a specific case study for all the hypersensitivities since there's all 4 of them, but we'll get into more with anaphylaxis. But type 1 hypersensitivity, remember that's where anaphylaxis comes from. It's allergies and anaphylaxis, and it's IgE mediated. It's typically the one that you're going to see the fastest. Type 2 is where we have our transfusion reactions, right, and our hemolytic anemia. And this one is IgG or IgM. Type 3 is our autoimmune disorders. So when we start talking about autoimmune disorders, this is type 3 hypersensitivity. And then type 4 hypersensitivity, that one's our one that takes a little bit of time, right? So it's the days to weeks, and it can be that Stevens-Johnson syndrome. So that's the one where you have the horrible rash. I can't even call it a rash. It's really gigantic, red, scaly, but weeping sores all throughout their body. I mean, you guys remember seeing it. It's significant amount of swelling, significant amount of weeping from it, open, some of them are bleeding. It was terrible. So that one's our T cell mediated, our type 4 hypersensitivity, right? Okay, so a little review. This is that same next gen case study, but we'll do it all together. So the next gen case study, there's an 8-year-old girl. She is taken from the lunchroom to the nursing office with respiratory issues. The staff noticed her face turning red and breathing altered while eating lunch. Student reported trading a candy bar with another student. Student has increased work of breathing, increased respiratory rate, and stridor. Facial swelling and urticaria and itching are present. And those are her vitals. So that 94% pulse ox definitely doesn't look good. Her respiratory rate is a little bit fast. 120 for a pulse for an 8-year-old, so it's a little up there. So we're definitely watching that. And then you can also see, I'll turn my little laser pointer on. You can also see the baby over here that's got the vomiting, urticaria, behavioral changes, the coughing, wheezing, and stridor. Okay, so remember, vomiting can be sometimes one of the first signs, and it's pretty consistent and significant. So we want to figure out which one she wants to do first. So she's got orders for diphenhydramine, epinephrine, injection, and albuterol, and then activate EMS. So I know we did this in class. Remember, we want to do our epi first, right? Epinephrine first. So their answer was doing epinephrine first and then activating EMS. And then we're going to be doing our albuterol because we can't give her PO diphenhydramine if she can't swallow anything, right? So that's definitely not going to be something we're going to do immediately. And then this picture shows you the injection for epinephrine. Remember, it can go right through the clothes. So what happens? So we do what we are supposed to do. We give her epi, we call EMS. We place the student in a recovery position. So we're sitting her up and helping her breathe. The facial swelling and the urticaria is reduced, breath sounds are normal, family is notified, and we are continuing to monitor. Vital signs remain stable. Facial swelling and urticaria are no longer visible. The child just says, my head feels funny. So what does epi do? So it's going to raise her heart rate for sure, and that might be making her head feel funny. It also might be the fact that she wasn't able to breathe for a little while there. So that could definitely have caused it too. She might be feeling a little lightheaded from her heart rate racing. So that's because of the epi. It's doing what it's supposed to. We are expecting it, but it's still considered a decline in her status because her heart rate is racing. Okay, so we can see that right here, went from 120 to 140. But everything else looks better. So 97% for her pulse ox is much better than the 94%. And her respiratory rate has gone down from 38 to 24. So that's definitely improved. She does not have the facial swelling anymore or the urticaria. So that's definitely good. Okay, so we are switching to hypersensitivity type 3, right? This is autoimmune diseases. So the two that you are asked to learn right now, because remember you've learned about MS before, now we're doing lupus and rheumatoid arthritis. And I'll be honest, really, we could have done, especially rheumatoid arthritis, we could have done both of these together with MS, because there's also some mobility issues with these too, especially because we have some swelling. So our story here is Katie is a 34-year-old woman. She comes in with bilateral joint pain, fatigue, and mild swelling in her joints. After ruling out other causes, they did an x-ray. They couldn't see anything that was going on with her joints that was an ortho cause. And she had significant swelling. They decided maybe they needed to have her go to a rheumatologist, okay? And so just kind of looking at the differences, because this is just somebody that's really just coming in with joint pain, fatigue, and mild swelling. Let's look at our differences. So we have joint pain, fatigue, swelling, and inflammation, and a low-grade fever. Are all three in our, or all four in our little overlap circle right here. So you can see them both with lupus and with RA. Now with RA though, we have the hand and foot deformities and the rheumatoid nodules and the redness or warmth near the swollen joints. With lupus, we have photosensitivity, unexplained weight loss, butterfly shaped across the cheeks, and hair loss. And let's see what happens. So remember the differences between doing the diagnosis for this. So really, you're going to have a lot of the same stuff, right? So ANA is definitely part of it. The ESR, we're looking at inflammation. Same with the serum and complement levels as well. So really, it's like I said, there's no one absolute diagnosis, but it does give us an indication that there's an autoimmune disease, and then we can prove that there is inflammation. And those two combining factors, depending on what their symptoms are, can give us the diagnosis of lupus. Lupus is a hard one to diagnose, though, because of that reason. Okay. And then looking at rheumatoid arthritis, so the rheumatoid factor is one of the things that we can check for, and that's going to, again, not positive doesn't necessarily always mean that they have to have rheumatoid arthritis, but it definitely gives us an indication that they could, right? And then the anti-CCP is the same thing. So we're looking for, it's a way that is more indicative of rheumatoid arthritis. ANA, same thing as the other one. ESR, same thing as the other one. And actually that CRP, I'm sure that they would have done that with lupus as well, even if the other slide didn't say it. But the one big difference with RA is we can do an arthrocentesis. So we can remove a synovial tissue biopsy, and that helps us see if there's inflammation. Okay. Now, we're going to diagnose her, and we're going to say that she had rheumatoid arthritis. Now, I know you're thinking to me, well, that was mild swelling. Are you sure about that? Yeah, the reason why I'm going to diagnose her with that is because we really want you to know those rheumatoid arthritis meds, because it's going to help you know the lupus meds as well, okay? And so let's look at the medication. Okay, so this just reviews our rheumatoid arthritis. Remember, I wanted to diagnose her with this so we could kind of review these medications. So the big thing is, of course, is educating about avoiding infection, monitoring their temperature, that kind of stuff, avoiding crowds, washing hands, all of that. And then a lot of these medications are injections, so teaching them about how to do an injection and site reaction concerns and that kind of thing. And then we're going to monitor their white blood cell count, because if we're immunosuppressing them, we want to make sure we don't immunosuppress them too much, right? And we're going to watch for opportunistic infections as well. So those are all big concerns. Two other things I want to mention. So in our next slide, we'll talk about methotrexate. So methotrexate is definitely used in RA. It wasn't one of the medications that your book actually talked about as one of the main ones, but it doesn't matter. It definitely is used in RA. Happen to have a friend on it as well. So we'll review it again, but you guys did learn it in A7. That's also one of the reasons why I didn't stress about it. Corticosteroids, that was something I really wanted to talk about and just make sure that I hit on it pretty well. So corticosteroids are, we always want to teach our patients what? To not stop them abruptly, right? Super important, super important. And I told you guys that it was about adrenal crisis. So one of the cool things about steroids is that you can learn about two different diseases just by understanding steroids. So when we talked about how steroids cause what? Cushingoid syndrome, right? So you're learning about Cushing's disease just by knowing the symptoms of too much steroids. So things like hair loss, things like hair growth on your face, but no growth on your head. The moon face, right? Acne, the fat deposits. So gaining, weight gain, edema, acne, that kind of stuff is the side effects of steroids. So you can imagine that most people don't really love those side effects. And that's why it's so important to make sure you teach the person about how you don't want to just suddenly stop steroids. It's important to continue taking them and taping them off when you are stopping them. If you're going to stop them because you really hate the side effects, definitely contacting the physician and working with them about a plan on how to stop them is what we want to talk to our patients about. Like, you can't just stop it abruptly. And I told you guys it causes something called adrenal crisis. Well, one thing that's cool about what it causes is that's another disease as well. So Addison's disease is adrenal crisis, right? They're the same thing. So, well, I mean, one's actually a disease process, one's not. When you stop steroids, your body has been used to this level of steroids and it goes into adrenal crisis. Well, Addison's disease is too little steroids. So if you can understand adrenal crisis, you can understand Addison's disease as well. So we have hypotension, we have joint pain, we have hypoglycemia, the exact opposite, right, of too much steroids. We have hair loss as well, kind of in both. Back pain, fatigue, and here's the big, scary things. We have loss of consciousness and confusion, right? So those are the things about how stopping steroids can actually kill your patient. We want to be really, really, really careful about how we educate them on that. Okay. Okay, so these medications are also used in RA. Now you see a few new ones, so don't worry about this one. And then these are just another class of this one right here is another class of the etanercept and the infliximab, which was on your other PowerPoint. So big things to know about them. It's kind of stuff that we already know. You know, you have the myelosuppression, you have the concern for like things like hepatotoxicity is common with methotrexate. We already knew that. We already knew that we were also concerned, about the kidneys as well, and that they are teratogenic medications, which means not to do them during pregnancy. And then concerns for like our glucocorticosteroids, this osteoporosis, hyperglycemia, that kind of thing. And then of course not stopping it abruptly like we just talked about. Okay, so just another slide to review it. Okay, so like I said, Katie is going to be diagnosed with rheumatoid arthritis. She's prescribed etanercept and steroids. Important teaching points for Katie is teaching how to inject etanercept, watching for site reactions, concern for Stevens-Johnson syndrome, and immunosuppression teaching, right? Steroid teaching includes never stopping steroids abruptly and immunosuppression teaching as well. Okay, next slide. So our next one that we're going to do is leukemia. So Alex is a 5-year-old who presents to the ED. Last month he's been complaining of being tired. Says his legs have hurt for the last 4 days. Mom noticed some red spots on his stomach and extremities this morning and a fever. So these are examples of petechiae and purpura, right? Real quick, let me just apologize for the constant stuttering and stopping. My 5-year-old happens to be home unanticipated. So if there's any interruptions, I apologize. I'm doing my best. Okay, so the CBC. So we get to see Alex's CBC. So his white blood cell count is very elevated, right? 34.8 in comparison to up to 11. His hemoglobin count is 9.9, so it's down, so he's showing anemia. His platelets are significantly lower than they should be, 45. So that is definitely alarming. His neutrophil count is 82%. So that's elevated. His lymphocytes look like they're down. His monocytes look like they're right in the middle. His eosinophils are right in the middle, and his bands are high, right? So bands, remember, are the immature white blood cells. They're the immature neutrophils. And so we see that his neutrophil percentage is really high, but we also see that a majority of those are actually immature baby white blood cells, right? And so this is like a classic picture of what a CBC can look like if you have leukemia. So what's our plan? So if you guys remember, he did have a fever yesterday. So that's kind of one of our big concerns right now because we already know that he is immunosuppressed. So an infection can kill this little kid. So we need to make sure that we get that under control. So we're going to admit him. They're going to want to repeat the CBC because it was abnormal. You want to always check that kind of stuff. Do blood cultures. Do a BMP, CMP. A chest x-ray, see if there's any pneumonia, anything else that's going on, and do a urine culture as well. So we need to really find the source of the infection and then plan to treat it. And that's going to be kind of our focus for him right now. Do we think that he probably has leukemia? Yes. Can we diagnose it just yet? Actually, no. We have a good idea that that's where it's going, but right now the first focus is infection. So we're going to put him on neutropenic precautions, right? So we know that he's immunosuppressed. We know that he has this huge risk for infection right now. So that's our focus. We'll have him on strict eyes and nose. We're going to give him a normal saline bolus initially. We're going to plan to start him on antibiotics after those cultures are done. We're going to do some Tylenol for that fever, vital signs every 4 hours, and we're going to be, we know to anticipate that we're going to be planning for a bone marrow aspiration for confirmation of leukemia, okay? And our next little kid, we have Adrian here. So Adrian is a two-year-old. His mom brings him to the clinic. Adrian's had throat pain and has had a high fever, Tmax of 103.2 over the last 24 hours. His mom was managing the fever with acetaminophen and ibuprofen, but is bringing him in due to increasing concern. She said, "He just doesn't seem like he's okay." Adrian presents with a heart rate of 143, so elevated, right? Respiratory of 38, so that's on the higher end for sure, and that's a little bit elevated. Temperature of 102.9, definitely high. Blood pressure of 89/50, so on the cusp. Adrian has audible stridor, excessive drooling, and difficulty swallowing. What are we thinking? Well, it's on the top. Epiglottitis, right? So the nurse immediately notifies the provider and honestly would consider calling for a rapid response depending on Adrian's level of dyspnea and oxygenation status. So if Adrian came in and she felt like he was definitely unable to breathe, then she would be calling a rapid response. If she or he, the nurse, if the nurse checked the SpO2 level and the SpO2 level was down, then they would be calling a rapid response. So the nurse must anticipate the need for rapid response kind of from the beginning, right? And anticipate the possible need for intubation and tracheostomy. What's going on? So we have the epiglottis of the throat, right? Is an essential part of the throat. I wish I had a picture. It's very hard for me to get one right now, but it's an essential part of the throat. And so when it starts to have this significant inflammation, it can completely close this kiddo's airway. So that's big. And if we are to that point that he is severely drooling and has excessive salivation, it might already be to that point, right? So she needs to anticipate, they need to anticipate possible intubation or tracheostomy, because this kiddo needs an airway. That's true. So if he is stable and we're not quite to the point of intubation, or if we've already intubated, the standards for treatment, and I don't think we talked about this in class, and honestly, the evolved slides didn't really help indicate it, but digging in enough definitely would be antibiotics. So IV antibiotics would be a concern, because in the book and everything, it didn't really get into detail about whether it was viral or always bacterial. But it looks like they always just treat it as bacterial, so bacterial cause. Steroids for the inflammation, and parenteral hydration, IV hydration. And then if you are not intubated, then you would do like humidified oxygen as well. Okay. Now we're going to go on to croup. So kind of separate epiglottitis a little bit from croup, even though a lot of times they're taught together. And they are taught together. But the reason why I say that is because everybody thinks croup, they think barking cough. One thing significant about epiglottitis is that you actually don't have a cough with epiglottitis, okay? You don't have that same cough at all. So with croup, I chose the laryngotracheobronchitis one because it's the most common. Cassie, she's an 18-month-old. Her mom calls the clinic and reports that Cassie had a barking cough, fever of Tmax of 100.9, and has seemed worse at night. What questions does the nurse ask? So some things that the nurse would want to know is signs of respiratory distress. Do we see any of those? If the mom is concerned, bring her into the clinic, to be seen. But if we don't see any signs of respiratory distress, if she seems like she's able to breathe, then overall we can probably manage this at home. But we want to be aware that the mom knows all the signs to bring her in for. So even though she's 18 months old, still saying the nasal flaring, retractions, difficulty breathing, just if she seems like she's having significant difficulty breathing, bring her in. Definitely would be what we'd want. Okay, some of the recommendations that we could do for her, and so we definitely want to have humidified air. And when I was trying to look about whether it was going to be warm or cold, yeah, most of our books say cold air, even if it seems so counterintuitive to me. And they were talking about, I think my afternoon class, or actually both my morning and afternoon class, I think brought up that maybe the cold air had to do with the decreasing the inflammation. And yeah, that definitely could be it. So either way, humidified air is the absolute recommendation that we'd want to have. And telling them, if it's I think just telling them, if it's a rainy day, bringing them outside or bringing them into like a room with a shower going is going to help. So just knowing that is important. Okay. So Tanya is a 48-year-old female. She presents to the outpatient clinic in response to contact tracing for possible TB exposure. Tanya was recently traveled to Asia with a tour group. She has a history of coughing, mild fatigue, loss of appetite since return 3 weeks ago. She complains of chest pain 4 out of 10 when she coughs. She's been taking over-the-counter cough medication with limited results. Lung sounds are diminished bilaterally with mild crackles noted in the bases. Her blood pressure is 120 over 76, 118 over 72 standing, so no concern there. Heart rate 78, that's overall good. Temperature of 100, we don't like that, especially for a 48-year-old person. It doesn't take much of a temperature for us older people to have infections, okay? We're not like our kiddos that get like 103 temperature just by having a virus. So respirators of 20, pulse ox of 95%. So she is currently on hydrochlorothiazide because she's got hypertension. She's on atorvastatin for hyperlipidemia and amylotriptan for migraine headaches. So what are her 3 assessment findings that are most concerning at this time? We do not like the fact that she's got a temperature, we don't like those lung sounds, and we don't like that pain in her chest. Those 3 are concerning for us. Okay. So if we were to look at TB, because we know that that's kind of what we're thinking about right now, and figure out whether she has risk factors, let's look through it. So client's overweight, that's not really a risk factor. Medication list, not a risk factor. Recent travel to Asia, that is a risk factor. That's a more TB common country, I guess you could say. Extended travel with a group, also a risk factor. Temperature, risk factor. Blood pressure, not a risk factor. Cough, risk factor. The pain in the chest she's experiencing, that's a risk factor. Let's look at her lab values. So her white blood cell count is elevated. Her platelets are normal. Her hemoglobin is a little on the low side. Hematocrit's a little on the low side. That A1C is higher than we'd like it to be. Her cholesterol is elevated. Her AST is good. Her ALT is good. Her sputum culture is pending. And she's got moderate bilateral pleural effusion, which can give us an indication for what? TB. So the nurse would recognize the client's priority problem is to address, what do you think? A, risk for spreading, B, gas exchange, C, pain, D, altered tissue perfusion. I'm going to be honest with you. I have a feeling there's probably some people out there that are thinking gas exchange, right? Because we're always saying ABCs. Yeah, ABCs are important, but overall she's stable, right? So think about what you would really be concerned about if somebody came in with tuberculosis that was stable and coughing up a storm in your clinic. Risk for infection, right? Definitely our concern. So her orders are rifampin, I believe, and moxifloxacin, and isoniazid, and pyrazinamide. So what are some of our teaching for her? And this is whether it's appropriate for us to, actually this is not our teaching yet, our teaching's coming up. These are our interventions. What interventions do we want to do? So implement a fluid restriction while taking TB medications, that's not appropriate. Initiate a 24-hour urine collection, not appropriate. Instruct client to wear a mask when and around others for the next 3 weeks. That is appropriate. Teaching coughing and deep breathing techniques. Appropriate. Alert client's family that she has TB. Not appropriate. Do we want to tell the client that she should tell her family that she has TB? Yes. Encourage a high carbohydrate diet. Not appropriate. Withhold opioid pain medication. Not nice. Not appropriate. Apply an N95 mask on us? Yes, definitely appropriate. So what is our immediate teaching priorities? Do we need to tell her that her cholesterol is high right now? No. Do we want to address it next time? Yep. Do we want to tell her that she's going to have to take these medications every day for the next 4 months? Absolutely. Do we want to tell her to continue, if she continues to cough at home, to save all of her sputum? No, that sounds terrible. Do you want to tell her that she's going to have regular labs checked because of the effects of the medication on her liver? Absolutely, right? Do we want to tell her to try to pace your activities to preserve your energy? Yes. Do we want to tell her that tuberculosis is not spread by germs on dishes or linens? Okay. Do we want to tell her that her A1C is high and she may have diabetes? Maybe not right now. That sounds kind of mean, right? And we also want to see what she looks like when she doesn't have this infection going on. Because remember, stress can raise their blood sugar. Although technically, I'm not sure it would raise their A1C that fast. But another piece that it doesn't say. Remember, with our rifampin, what does it do? It's gonna turn her urine orange red. All of her bodily fluids that orange red color. So I would teach her that too. Client returns for a follow-up appointment 4 weeks later after being diagnosed with TB infection. She reports missing several doses of medication. She continues to have a reductive cough and is tired most days. Lung sounds clear with a few scattered crackles. Rates pain 3 out of 10. She's got a temp of 98.8, pulse of 80, respiratory 22, BP is 144/88, pulse ox is 95, white blood cell counts 9,000. Mild pleural effusion in the right basis on her chest x-ray. So overall, she's improving, but she did report that she's missed several doses of medication. So that is concerning. We have to talk to her about medication compliance. That would be our absolute priority right then. Okay, so our next one is a asthma next-gen case study. You guys remember it, but we're actually going to go through it all together. I don't think one of the classes, I think we didn't finish the whole thing. So just in case you didn't go through it. So the nurse cares for a 23-year-old male in the emergency room department who's experiencing acute onset of shortness of breath. Client reports shortness of breath and chest tightness that's progressively worsened over the last 2 to 3 days. He has a history of seasonal allergies, is a non-smoker, and lives at home with his mother, who's a current smoker. Denies fever or vomiting. Describes feeling fatigued and has a dry cough at night. Audible and expiratory wheezing auscultated throughout his lungs. Increased respiratory rate noted. Capillary refills less than 3 seconds. Skin warm to touch. Chest wall is symmetrical with no deformity. Client sits upright and leans forward, resting his hands on his knees in a tripod position, and speaks only through a few words between breaths. Tenderness on palpation of chest wall. Trachea is midline with no deviation. Labs drawn. Chest x-ray ordered. So let's look at his vitals. His respiration is pretty high for a 23-year-old. Overall, that's the one vital that stands out the most, right? So, which findings require immediate follow-up by the nurse? So, shortness of breath, chest tightness, respiratory rate, dry cough, audible and expiratory wheezing, tripod position, speaks only a few words between breath, blood pressure, tenderness of chest wall. What do we think? So, really, that shortness of breath is very concerning, right? We see that he is he's experiencing the chest tightness. He's having that audible and expiratory wheezing, so we clearly see that he's having trouble right now. He's got the tripod position. He speaks only a few words between breaths. So all of these would be concerning. So we would want to make sure that that's being addressed. That his respiratory rate, we already had talked about that too. So these would be definitely something that would stand out to us that we would want to notify the provider about. Right? They require immediate follow-up. So next one, we want to figure out his risk factors, right? So risk factors for asthma is what we're thinking about. So his family history, let's see. So family history would be considered a risk factor. He's got the history of seasonal allergies, and I don't see anything about family history for him though. but he does have the history of, he does have the seasonal allergies, and his mom's a smoker. Beta blockers, if he was using beta blockers, that would be a risk factor, especially for asthma. And then viral infections, if he had viral infections, that would be a risk factor. Smoking, overweight, all of those are risk factors. Edema and diabetes are not considered risk factors. Okay, so the nurse should recognize that the client is most likely experiencing, we see his vital signs right, not vitals, his labs right there. So overall, everything looks good. Yeah. Overall, everything looks what we would expect it to be in range, except that chest x-ray that shows hyperinflation of lungs with flattened bases of the diaphragm. So we would be concerned for asthma with this. We know that he's most likely experiencing acute asthma onset. His vital signs, shortness of breath with expiratory wheezing, definitely tell us those things, right? So which of the following interventions should the nurse anticipate, including the plan of care? So we want to give him oxygen if it's less than 93%. We would want to do an albuterol treatment. We would want to do raising the head of the bed, definitely. Administer solumedrol would be important as well, right? So making sure that we did that would be our goal for managing him. So we have orders to monitor his pulse ox, administer 2 liters of O2, albuterol 2.5, nebulizer treatment, the ipratropium, which is the longer acting bronchodilator, every 6 hours, and getting him an IV and starting the solumedrol, and instructing him on the peak flow meter. So what are our priorities? So right now, our biggest priorities are going to be doing that 2 liters of oxygen nasal cannula. Remember when we're doing any sort of treatment, so if you're sitting there like, well, it said put an SpO2 monitor on, but I really want to give him albuterol. You really can't treat somebody their oxygen status without knowing what their oxygen status is. So you kind of have to put that SpO2 monitor on. Just like when we were talking about suctioning a trach, you would never suction a trach with an SpO2 monitor on. You have to know what their oxygenation status is. You have to. So we would definitely want to do our SpO2 with our 2 liter. Our solumedrol is going to be done. Remember, we're not going to like not do our albuterol just because our solumedrol says stat, though, right? So if we still need to start an IV, I'm not going to be like, you can't breathe, but hold on 1 second, let me get your IV. Not going to work. So I'm going to give him the albuterol and the ipratropium. I can start his IV while that's going. There's no reason why I can't. Okay. So that would definitely be something that I'd want to do first. Okay. So then what happens? He gets all of his medications. They order the bronchodilator and the corticosteroid is completed. Clients experiencing extreme labored breathing, confusion, and increased heart rate, blue-tinged lips, prolonged expiratory wheezing with chest tightness on assessment, reports having difficulty catching his breath when he's lying down. Now his vital signs, look at that. So his pulse ox went from 95%, 93%, and now it's 85%. So remember, even though I'm like going to be giving him the bronchodilators, I have to have that pulse ox on before I can treat it. His pulse is 128. His respiratories are 38. This does not look good, right? So what do we think is going on with him right now? So we think he's in status asthmaticus, right? So what do we do? So we are going to administer epinephrine. So we can do the nebulizer epinephrine and high flow oxygen. And we know that he is most likely experiencing status asthmaticus, and we want to monitor his pulse ox and his respirations for sure. Okay.